Hi, everyone. Welcome back. This is Scott Allen. I'm the CEO for the Family Medicine Education Consortium. And welcome to our fourth learning session in the Bring Your Brave Hereditary Breast Cancer Project. We're really excited tonight to have a guest speaker who's going to address some of the questions I think you all have been having as you work through this project. So welcome. Just a couple ground rules to cover as usual. Please go ahead and feel free to use the chat to ask questions or make comments or share anything that you think of during the session. We'd love to see you put some comments in the chat. Remain on mute when you're not speaking, but we are going to have Q&A, and you're welcome to unmute and put your camera on to ask questions. And then you can go ahead and use the reaction buttons to raise your hand or share your reactions. For anybody who's new, I know we invited some participants who maybe weren't in the core teams at your family medicine residency programs tonight. So for anyone who's new, just a mention of the project itself. From December to July, we are working with 10 family medicine residency programs in 6 states and DC to talk about the CDC's Bring Your Brave campaign and figure out how we can use that campaign and its materials to work in training and in clinic, and how narrative medicine principles behind those campaign materials can prepare residents to navigate hereditary cancer conversations with patients. So if you haven't seen the Bring Your Brave materials, which most of you have because you've been part of the project, please follow the link and go take a look at them. They're great. Tonight, we're going to hear from our advisory committee member, Susanna Evans, give a little bit of an overview, just to kind of touch base on the refresher of what we're talking about. And then we have a guest speaker, Linda Massart, who's going to talk about the intersection of genomics and family medicine. So just for background, Susanna Evans is the academic chair of the Department of Family, Community, and Preventive Medicine at Drexel University College of Medicine. And our guest speaker tonight, Dr. Melinda Massart, is a family medicine physician at UPMC and assistant professor at the University of Pittsburgh. She also serves as the founder and medical director of the UPMC Primary Care Precision Medicine Clinic and as the associate director of clinical services for the Institute for Precision Medicine. So with that, I'm going to turn it over to Dr. Evans.
I'm going to go ahead and share my screen. I have just a couple of slides. So for those of you who were present for, I think it was the first session, I did a little introduction, and when I went back to kind of put my slides together for this one, I'm like, well, I already have the slides. So just kind of change things up a little bit, but really what we want to talk to you about tonight is genetic risk assessment for early onset breast cancer, and why we as family physicians need to be doing it. A question I have for the group is, like, when do you think maybe I should recommend genetic testing for my patient? I don't know if anybody feels like they want to unmute and give me a scenario, or you just want me to keep going. All right, so I'll tell you. Go ahead.
I had a patient just this afternoon. She had 3 aunts with breast cancer and another aunt with ovarian cancer.
Yeah, and I think that's always what hits me, right? Is that it's often a new patient visit, or it's a physical where I'm going through the family history, and they say, "Oh, my mom had breast cancer." And I say, "Oh, well, how old were they? And who else? And an aunt." And then as the story starts to come together, or last week it was somebody, my mom had breast cancer, and my uncle had colon cancer, and my great aunt had ovarian cancer. And I'm like, whoa, we need to think about what your risks are. And what resources do you use to determine risk or the need for genetic testing? Does anybody have resources built into their EMR, or is there anything that they go to pretty regularly?
I used this one. I think I got it from one of our teachings, the breast cancer genetics referral screening tool. Have you heard of that?
Yep. So that's actually, and that's one of the ones that you can access through the Bring Your Brave site. I have in my EMR, I have the Gale model. I tend to use that. Where I got these links, basically was I Googled provider resources, Bring Your Brave. And it took me directly to this information. And then I just really wanted to highlight, why this is really important. 9% of breast cancers occur in women 45 and younger. Women in this age group are more likely to have a hereditary breast cancer. Breast cancer in this age group is found at a later stage when it's often more aggressive and difficult to treat. And many young women do not know their risk for breast cancer and ways to manage their risk. As family physicians, we need to identify women at higher risk for breast cancer and refer them for appropriate testing or screening, or maybe not refer them, and we'll talk about that. According to the Bring Your Brave campaign, only 41% of primary care physicians refer a woman with high risk to breast cancer, with high risk for breast cancer for genetic counseling or testing. And this is just another study that basically highlighted that we're really missing the patients who have a high risk and not getting the genetic testing done. And this is just some of the risk factors for early onset breast cancer, things that might come up in your conversation that would make you think, this patient probably should consider genetic testing. And I'm going to go ahead now and just turn it over to my Linda, because I feel like that's going to be really the meat of what we really want to cover today.
Thank you so much. Let me just share my screen. And if I can just get a thumbs up that you're seeing the right view. Awesome. Great. Well, it's so great to be here tonight. And thank you for inviting me to speak, and Dr. Conti for recommending that I come to speak on, of course, my favorite topic, which is the intersection of genomics and family medicine. And I think that while I don't necessarily have all the background and details of the project that you're working on, I was introduced to this and some of the questions that were coming about, and so wanted to share this presentation with you tonight. So why does genetics and genomics make the most sense in family medicine? And this is actually kind of the heart of my entire career, and trying to not just promote this here locally, but across the country, that really the place that makes the most sense to talk about genetics and genomics is in family medicine for many, many reasons. One, we're the frontline providers. We are everywhere, rural, urban, everywhere in between. We take care of multiple generations in our patient populations, and we practice lifespan medicine and take care of patients across the entire lifespan. And when you think about genetics, it really intersects and impacts every one of those aspects of family medicine. The other main reason is that if you look at the number of trained genetic specialists around the country, there is a major deficit in being able to provide care to the patient population. So, oops, there's a typo here, but as of 2021, there were 1,860 clinical geneticists in the entire country. There's slightly more, almost 6,000 genetic counselors. If you look at the color of the map here, you can really see the darker represents the higher density of those specialists. So as you might expect, they are in locations where there are large populations or large academic institutions. Even if you look at our own state of Pennsylvania, they are pretty much localized in Pittsburgh and Philadelphia, but not much in between. I did the National Health Service Corps and practiced in rural Idaho. When I first went there, there are still no medical geneticists in Idaho, but there was one genetic counselor for the whole state. And that has since improved by them creating a genetic counseling program there, but clearly not enough located in a geographic space to serve the entire population. And as genetics and genomics advances, it is now impacting every single every single level of medicine and healthcare. And there are some very urgent needs for genetic knowledge, genetic testing, and genetic awareness in primary care. And these are just some of the examples. 1 in 12 Americans have engaged in direct-to-consumer genetic testing, whether it be ancestry or health-based, hereditary cancer, which is, of course, the topic that you're all reviewing, pharmacogenomics, and how our genes impact the metabolism of different medications, expanded carrier screening, non-invasive prenatal testing or screening, newborn screening that's becoming more genomic based, and then chronic disease and polygenic risk scores, and then many, many common adult genetic disorders that we care for every single day in the family medicine space. And now we're also starting to see a crossover where research results are being returned back to our patients. And where are they going to bring them? They're going to bring them to their family docs to look at and to receive guidance and advice on and how to integrate this into their care. So one of the questions that I spend a lot of time thinking about is how do we get genomics as another tool in our clinician toolbox? And I propose that there are really two types of genetics. There's genetics as the clinical specialty that we tend to think about, historically based in pediatrics, but has evolved to OBGYN and some adult spaces as well, metabolic genetics, rare disease genetics, and the classic genetic syndromes that we tend to think about. But now we really have genetics as a tool, right? So looking at polygenic risk scores, looking at hereditary cancer risk and pharmacogenomics and all of the things that we just discussed. And I make this comparison to, we have radiology as a specialty, which is expert level interpretation, interventional procedures, but we also have radiology as a tool that you and I order every single day in the clinic, right? We don't refer our patients who need an MRI to a radiologist to do an evaluation and order the MRI. We make that determination ourselves. If there's a finding that is significant, we then refer to the appropriate specialty clinician to manage that particular condition. Same with cardiology, right? Cardiology as a specialty, doing expert level interpretation, management, care, again, interventional procedures. But then there's cardiovascular as a tool, right, where we order these tests all the time. Again, echocardiograms, stress tests, EKGs, Holter monitors that we don't necessarily refer first to the specialist. We do the workup first, and then based on the results, send that down on to the specialist who's appropriate for caring for that patient. So I'd like to really think about us, all of us really start to think about genetics now as a tool. And it's really that tool that becomes integrated into family medicine. There are a lot of barriers to this vision of fully being implemented, and many of these barriers include testing itself, the availability, the cost, the reimbursement of the testing, the turnaround time to get results. On the clinical side, we still are lacking a lot of algorithms to guide our management and decision-making. We still need a lot more real-world randomized control trial data on outcomes and value of some of this. And lack of patient access to services, which is, again, I think a point where family medicine provides that access point. On the information technology, we need more data management. We need clinical decision support and point of care tools that we can access immediately when we are taking care of our patients. On education, we know there's a huge gap in the genetics education that our medical students and residents are receiving. And so we really need to advance that going forward. And of course, we need to continue advancing all of this in the context of the ethical, legal, social implications model. And we're going to talk a little bit later specifically about GINA, the Genetics Information Non-Discrimination Act, and how this protects and where it fails to protect our patient currently. So really, one of the main things we need are tools integrated into our electronic health record. And I think that we all probably have lots of thoughts and feelings about electronic health records and how they were originally designed and where they're evolving to. But they can truly be maximized and leveraged to be supportive for us in this process, especially again in family medicine, where we are managing such a huge, massive, broad scope of medicine and healthcare. Having this available at our fingertips is critical. So having orderables for testing that are simplified, reporting of results that can trigger and fire clinical decision support, and all of this ready at our fingertips dramatically needs to advance and is in progress around the country. We need a lot more help and guidance around cost and reimbursement. We need a lot of transparency in cost and reimbursement, clear pathways for doing this. You know, we cannot bog ourselves down in prior auth nightmares. This just isn't going to be effective. And actually, quite honestly, I think will turn clinicians away from actually delivering something of value to their patients. We need reimbursement models that make sense. And we need out-of-pocket costs when it's not covered that are affordable and accessible for everyone. And then in terms of guidelines and educations, you know, I believe that we should not all become medical geneticists, but we should become genomic clinicians, meaning we are competent to practice genomics. As a family medicine clinician, we do not need that formal training, but we need enough, and again, then the right tools to be able to successfully integrate this into the care of our patients every single day. We need to be able to meet minimal competencies, specifically in ordering, in pre and post test counseling or informed consent, which I'll talk a little bit more about, and interpretation of results. We need clear algorithms for who and when to test. Unless that can be completely eliminated by low cost. And I'm going to talk about that as well. And we need better integration overall into our medical and education. For testing needs, we need streamlined testing, right? We cannot have a bunch of nuances and guidelines that we're searching through and digging through and trying to remember with respect to each of our patients. And the cost of testing is coming down very, very rapidly. And I think we're really close to being the point where we will be able to offer just one single test, which will be whole genome sequencing. And that will massively simplify everything for us, but we're not quite there yet. So what do we do in the interim until we get there? And then, you know, do we do indication-driven testing? Do we do population-based screening? What do we do when we have secondary results that we weren't necessarily anticipating? How do we integrate all of this into the care of the patient? So most importantly, how do we simplify this for our actual clinical practice? So I am a big believer that in the near future, we will just have one test for all. And this one test will serve across the entire lifespan of our patients, will guide us in not just their care, but in their family's care as well. And to go into a little more depth about that, if we were able to do integrated longitudinal healthcare with one test, which would be whole genome sequencing, there are so many different time points across the lifespan where this can come into play. You can imagine if someone was sequenced immediately following birth, we could greatly shorten diagnostic odysseys in the NICU. We would be able to unmask only the results relevant to the time frame of the lifespan, right? So we could only look at disorders that could be relevant in the pediatric age range. And then when someone turned 18, they could elect to have additional results unmasked for things that might impact them as an adult, where they could integrate more proactive care and preventative care if they knew that they were at higher risk, including increased cancer screening. They might also want to know the types of things like carrier screening if they are interested in becoming a parent, or perhaps later at their very first prescription, unmasking their pharmacogenomic data at that point in time and being able to guide prescribing with that data. Or later on, they develop actual clinical symptoms of a condition, such as a neurological condition. That data is already there, and it can be requeried in literally a matter of minutes to evaluate whether there was a genetic finding that put this individual at risk for this condition, and may actually guide one type of treatment over another type of treatment. So this single genome, I think, is coming very, very soon. The cost now is already less than $500. And so when it gets to about the $100 rate, I think it will replace all other types of genetic testing. The data will be stored and it will be available for access again over the lifespan of each of our patients. So I wanted to talk a little bit about informed consent versus pre-test genetic counseling. I think historically, a lot of us have heard about the pre-test counseling that genetic counselors do. And it's really, really important to recognize that we don't need to become genetic counselors. We actually do informed consent all the time with our patients, right? Every time we're in the office and we're going to do a skin biopsy, we do informed consent. Even when we talk about basic lab work, we go through some minimal form of informed consent. This is something we are really experts at and well trained on, and is no different when it comes to genetic testing. And so I don't think that this is something that absolutely must be seen by a genetic counselor to be accomplished. It does need to be available in an organized way in sort of a checklist fashion, because we are busy and have a lot going on and need to be able to rapidly ensure that we're covering our informed consent basics with each patient prior to undergoing genetic testing. But it's extremely doable. And I think that one of the things that we have done so well in family medicine, again, is integrate this broad scope of practice into what we do every single day. I would say that most of us, based on our training and experience, do about 70% of every different aspect of medicine. And then we're really good at knowing where our personal limits are, and when we either need to call a colleague down the hall who might have slightly more expertise in something, or phone a specialty colleague across campus or elsewhere and refer that patient on for specialty level care. And I would say that genetics and genomics is no different than that. The real challenge right now is that most of us didn't get that education alongside all of the other types of education we received in med school and residency. And so it feels like we have to go and add a whole new 70%. But if we could integrate this earlier enough, everyone could graduate with the same competence and confidence as managing hypothyroid and type 2 diabetes as they could with genetic types of relevant conditions. So how do we do that, though? How do we get to that 70%? How do we achieve this education goal? And how do we support current practicing physicians to be able to achieve this goal? I think there are a lot of different ways to doing that, but ultimately we need to have everything as simplified as possible. And so I know earlier in the conversation tonight, before I started speaking, there was a question about, when do you offer genetic testing to a patient? What is it that you hear in that family history that would trigger you to have that thought? And even that is really a lot to ask the busy, everyday practicing family medicine physician, right? There are clear-cut red flags that should identify someone as being at higher risk, but we know that doesn't capture everyone. And every time we add a layer of nuance to this, it becomes more of a barrier to us actually being able to successfully integrate this into clinic every day. But it's really, really important, right? That's the whole point of this particular project. And through genetic cancer risk assessment, we are ultimately trying to risk stratify and identify the patients who need earlier and more aggressive screening, because they are at higher risk for developing cancer at a much younger age than the average population. We know that 5 to 10% of all cancers are related to an inherited cancer syndrome, and there are more than 50 different types of hereditary cancer syndromes out there. And most importantly, if we know who is at risk, there are important risk reduction opportunities that we can integrate into their care to again, decrease the risk or catch cancer as early as possible. And, you know, there is varying prevalence of risk in the population. On average, for non-high risk populations, the prevalence is about 1 in 400 for one of these hereditary cancer mutations. That goes up significantly in certain ancestries, like my own ancestry being Ashkenazi Jewish. And we know now that this is also significantly elevated in African-American women as well, which were very understudied, and therefore a huge delay in recognizing the frequency of these mutations as well in African-American women and anyone of African ancestry. And so it is critically important that we understand these different nuances, but again, every single layer becomes more and more complicated. So now you're looking at family histories, you're looking at ancestries, and trying to identify, again, who is high risk and who is low risk, and who do we offer genetic testing to. The opportunity, of course, is that, if we could identify and do the screening earlier, that we would, again, hopefully reduce the incidence of cancer, or at least increase the success rate of treatment of cancer. And it's really interesting that, we have known this for multiple decades now. We've had guidelines, national guidelines out for multiple decades now, but still less than 20% of eligible individuals who would actually meet high-risk guidelines by the red flags in their family history are actually being offered genetic testing. And the more underserved and more intersecting identities, underserved identities that an individual has, the less likely they are being offered these testing opportunities. And so this creates a massive opportunity in primary care for us to do better. So we know that the USPSTF has been recommending hereditary BRCA1 and 2 screening in certain conditions. However, they've been recommending for a long time against screening in the average population who don't meet one of those red flag conditions. And I think it's time that we need to reassess this, because if we're only even achieving 20% of screening in this category grade B, what else are we actually missing out there by those who don't come in wearing significant red flags? It's a big challenge and a big issue. ACOG, the American College of Obstetrics and Gynecology, has also had guidelines out there for quite some time around hereditary cancer screening. But it, again, doesn't give us the how to actually implement this right in the clinic. And the kind of gold standard for guidelines is the NCCN, which has very, very specific criteria. And probably many of you are aware that these are the guidelines that actually need to be met to be eligible for reimbursable hereditary cancer genetic testing. And so again, this is just layers upon layers upon layers of nuance, right? So really, really challenging. How do we expect our clinicians to keep track and manage all of these different aspects, all of these different guidelines, all of these different indications? This is just highlighting some of those most common hereditary cancer syndromes out there. And again, reviewing the general red flags that we should be aware of and looking for. And I believe someone mentioned this earlier, but there are actually several risk assessment tools that have been validated and are available for primary care, where we can quickly risk stratify our patients as being higher risk or low risk. But again, it's completely dependent upon them willing to share their family history and them having knowledge of their family history. And I think we know that in a lot of cultures, sharing and having conversations, especially around cancer, is a little bit taboo, right? Is not well supported. That information is considered to be really private, and we don't share that. And so, if someone doesn't have the incorrect information or understand the very nuanced difference between uterine cancer and cervical cancer and ovarian cancer, which we know most of our patients don't understand that difference, this could miss patients who are at risk. And just anecdotally, I will tell you that when I was in the National Health Service Corps in rural Idaho, I did a small pilot study that we risk stratified everyone who came into the office. And 1 out of 4 of our patients who walked into the office risk stratified as high risk and needed further evaluation to decide whether or not they met the criteria for hereditary cancer testing. 1 in 4, 25% of our population. And then I repeated that when I came to Pittsburgh at our federally qualified health center lookalike clinic at UPMC, and it was the same, 1 in 4 of our patient population, 25%. So that's a tremendous amount of work, right? And if we try to refer all of those patients then who risk stratified in a conversation with us to the rare number of genetic counselors that are out there, we will bog down and saturate the system. And in fact, that's already happened. So many of our patients, when they do get referred for genetic counseling, there can be up to a year or more long wait to actually get in and have this done. And so I really think it's time for us to perhaps evolve our thinking in family medicine, not that this is necessarily something we need to refer out, but actually something we can adopt and take on and be doing in our own clinics. And then if someone comes back with a positive result or a result that cannot negate a really significant family history, those are the patients we then need to get on to that genetic counseling specialist. I also think that, again, all of these different indication-driven or risk factor-driven criteria to determine who's eligible for testing, it's overwhelming and really challenging to integrate in real time in our clinic. And so I think there's really a paradigm shift that's starting to happen, again, because the cost of testing is coming down so significantly. And maybe in primary care, we need to think about an easier way, which is population-based screening, not risk-based screening, and actually offering this to all of our patients, right? And if the cost is low enough or it's reimbursed fully, then we don't need to worry that we're missing someone because they didn't hit enough of those NCCN criteria or enough of those red flags to remind us to do this. Population-based screening is available now, not just in hereditary cancer space, but also in pharmacogenomics, carrier screening, cardiovascular screening, and something called the ACMG 78, which is the American College of Medical Genetics 78 genes that are considered actionable, meaning if we found a change in one of those genes, that would empower the individual to actually do something in their lifetime to potentially change the outcome. And so these are all now available on the population-based screening side, but not yet happening on a consistent or readily available manner. But it's time for us to be thinking about this. And I think the project you're doing, projects like this, is a great opportunity to put that pause on and say, wait a minute, just because we've been doing this the last 20 years one way, doesn't mean that it actually makes the most sense anymore in 2023. And maybe we need to be evolving our thought and really thinking about integrating this on a whole new level, and that we can do it. The most important thing, I think, around any genetic cancer screening, whether it be breast and ovarian or colon or universal or population-based, is consistency in our offering. So how do we, again, practically integrate this into a busy clinic? I think this was mentioned earlier. Again, new patient and annual exams is a great time, right? It's when we review our screening in general and our family histories in general. And anytime the topic comes up, someone might come in and say that a family member just had a new cancer diagnosis, or perhaps they have a symptom that they're concerned about, that it could be cancer. So that's an opportunity. If we do that consistently over and over again, then we will achieve an equitable, at least, dissemination to our patients that this is available, although there is not yet equity in being able to access the testing across the board. And I think that you're never wrong, even though I'm making this argument that we don't necessarily need to refer patients to genetic counselors. I want to iterate that you're never wrong to refer patients to genetic counselors. We should always think about referring anytime we're not sure what to do. And if the patient is currently affected with cancer at this time, that's very appropriate to refer to a genetic counselor. And if you do the screening in your own clinic and it comes back positive, or again, it may come back negative, but it can't negate a really significant family history, that's really appropriate, again, to refer on to genetic counseling. And this is just a great resource if you haven't seen it before, that you can find genetic counselors all over the country through this website. I wanted to touch base a little bit too about direct-to-consumer testing, because this definitely came up in our prep call last week. And as I mentioned earlier, 1 out of 12 Americans have embarked on some form of direct-to-consumer genetic testing, ancestry or health or combination thereof. And if you're not aware, patients can also take their raw data from those types of direct-to-consumer testing and upload them into what's called third-party interpretation, and gain even more results than they even had reported by the direct-to-consumer company in the first place. It's really important to note that the genetic cancer testing that is done in direct-to-consumer testing is never going to be adequate unless it's positive. If someone brings you direct-to-consumer testing or mentions that they did testing and it was negative and therefore they feel relieved or reassured, it is important to educate them right there that is inadequate. It doesn't cover all of the different mutations, and then often it is not relevant to all ancestries, the mutations that are included and covered. And so that is a very false reassurance. However, if someone comes in and brings direct-to-consumer testing with a positive result for a cancer mutation, that is probably correct. So then that does become significant and must absolutely be validated. There are no direct-to-consumer hereditary cancer testing that are currently FDA approved for use in clinical decision-making. I have validated many. They've all been correct and accurate, but it is still absolutely required to validate in a clinical CAP-CLIA lab before we integrate that into the health record and before we use it for any clinical decision-making or guidance. And if you would like more information, because again, this is another layer of nuance, that's a lot to think about. There's a great resource on direct-to-consumer genetic testing on genome.gov website. And so the link is here as well. And I believe you'll all have copies to be able to access these slides. So you can take a look at this, and you can even go through an algorithm about what to do if a patient does bring in DTC results for you, and when it's important, when it may not be relevant, and when it should be validated clinically. The next thing I just wanted to quickly review, because I think whenever we're talking about genetic testing, it's so important that as part of that informed consent process, we do talk about GINA, the Genetic Information Non-Discrimination Act, which was put into place in 2008. It's great that it's there, and it has some great protections associated with it, but I would say in 2023, it is grossly inadequate, and a lot of lobbying needs to be done to strengthen GINA. Currently, it does protect individuals from having their employer use their genetic information against them regarding their employment status. It also protects patients from their health insurance using this information against them for their health insurance status, but it does not protect for life insurance, and it does not protect for long-term care insurance, and it does not apply at all if you are employed by the government. And so it has some very significant limitations. So it is not uncommon in our clinic that we'll have a conversation about doing genetic testing with someone and then find out that they don't have their life insurance yet. And so we'll pause the genetic testing and let them go and get their life insurance in place, and then have them come back and complete the testing after that's in place. So this is a really important conversation to have with patients as well. So I just want to acknowledge before we wrap up my team here at UPMC. So we have a primary care precision medicine clinic that we have built to explore what the integration of genetics and genomics looks like in family medicine, as well as integrating emerging precision medicine technologies. And we are looking at all sorts of ways to not only see patients in the family medicine space, but to support our family medicine colleagues around caring for their patients. And we have a multidisciplinary team, including a clinical pharmacist who's an expert in pharmacogenomics, 2 amazing genetic counselors. I think they're the first 2 primary care genetic counselors in the country. And we now have a nurse practitioner and also a resident who's doing his additional optional training with us in our clinic so that we can continue to train the future and how to move forward. And with that, I will end and maybe we can open up for discussion and conversation. Or I've put everyone to sleep.
If people are comfortable, unmute and ask a question. If you're more comfortable with putting something in the chat, we can try to pull some questions from the chat. But I think this whole idea of putting the genetic counseling, or at least the genetic testing, into the hands of primary care doctors, it makes a lot of sense to me. And I'm just kind of wondering what other people are thinking, what some of the barriers you might see.
I agree. I think that would definitely expedite the process and getting, if someone's going to be referred for treatment or prophylaxis, that would expedite the process. I think there definitely needs to be like that CME and definitely incorporate it into residency training, for sure. Because I do feel like these things are often, overlooked, unless someone's there for a physical or they're a new patient and you're entering that information.
And I think it's really also important, in addition to that, to make sure that we also encourage our patients to find out more about their history itself, because I feel that that's something that isn't talked about too much, or we don't necessarily always encourage. We kind of expect people to know this, but especially that as primary care doctors, we're going to be seeing people of all ages. I think it's really good for us to also encourage that moving forward, and also to let everyone else know also that this is something that's emerging. And I think that was one aspect that I was thinking of as well. That would be a barrier, because if our patients don't know their history, then that's what leads us to maybe also not picking up a lot more cases. But another thing that I really liked what you said was how it should be incorporated into population-based strategies. And I think that would be really important. An aspect of that I was wondering is, would you think that if that was practically moved into moving forward, if that was something that gets incorporated in, do you think that it would have a lot more costs in the down run, where a lot more people that don't need it are being tested?
Yeah, so I think there's a trade-off there, right? So there's the cost of not detecting that someone's at high risk, and then only detecting when they develop their cancer. And many cancers progress present at very advanced stages, so are very, very costly, and then we don't save many quality years because of that advanced diagnosis. So there's that cost offset with the screening cost, right? And there is some sort of economic balance that has to be achieved with population screening, and that's why it isn't fully in place yet, because we haven't yet fully reached that place. But I do think in terms of screening patients on the population level then removes exactly those challenges that you just said, right? If someone doesn't know their family history, or what if they just didn't happen to have a family history? They had a very small family and it hadn't shown up yet in any recent generation. Or they are not aware of their ancestry, and so they may not know that they're at slightly higher risk than the average population, or even significantly higher risk than the average population. So going to population screening eliminates that need to know or recognize or identify the family history red flags or the ancestry red flags, and just kind of allows that equal playing field for everyone to be screened. And then those who are identified as having a high-risk mutation to enter into a more aggressive screening and treatment and preventative plan. So I think it would be very, very helpful, but you are right that there is a cost ratio there that will allow this to either be successful or not.
Thank you. It was really good to like hear your viewpoint regarding that, because that's kind of what my curiosity was in that sense. But perfect, thank you.
I can see, I came late. Nice to meet you. Wonderful talk. Sorry I missed the first half, but it's been recorded, right, Rebecca? All right. But I can see instituting an algorithm of sorts that could perhaps be made into a template for EPIC, for example, for those very patients that are higher risk. We either, as you just mentioned, are not familiar with their family history, and I've certainly had cases of that. I know that my grandfather had a cancer, but I can't identify which. And the other day I had a patient who did 23andMe and found out they had a significant Ashkenazi Jewish hereditary makeup, of course, which raises the risk significantly for various cancers. Yeah, so I think we could have a significant proactive role in some way, shape, or form that could be generated out of this project to implement for more.
Yeah. And absolutely, those tools are essential. And I work with some teams right now who are looking at exactly that. How can we build tools that can not only help us identify patients at higher risk who should be offered the screening, but hi, sweetie, there's a sweet baby online. I love all children and all pets on any virtual call. They make my day better. So we need tools that not only help us identify and risk stratify the patients, right? If we're not doing population-based screening, but risk-based screening, but then on the backside, we need the management tools, right? Because again, we also cannot send everyone who screens positive to a high-risk clinic to manage the patients, because again, they're being saturated already. And these are all things we can do. We know how to order mammograms. We know how to order memorize, right? We know how to talk about breast exams. We can talk about prophylactic hormone treatment. If we are reminded by our tools when to have those conversations and can be reassured that we are providing those conversations every year and going back through that checklist. So I think those clinical decision support tools integrated into our electronic health record are absolutely critical for us to take this next step forward in family medicine. I'm curious to think what do you all feel about my proposal around going to one test? Like, let's simplify this massively and not even have different buckets of genetic testing, but literally one genetic test, if we could get the cost low enough.
I missed that part. What would the test be? It's just
whole genome. It would be whole genome sequencing.
Whole genome sequencing.
Yeah.
I think it has so many implications beyond what we're talking about in this group, but even just sort of experimentally at Drexel, we're using pharmacogenetic testing to try to figure out like what was the best antidepressant or class of antidepressants to use in somebody, and felt like there was some very promising research there. And we operate in trial and error right now. And if we could take some of that away, I think that would be hugely helpful.
Yeah, and tying it back in specifically to the topic that this group is working on, right? It would be about making that, again, shared decision with the patient of when do you unmask those hereditary cancer results, right? So again, I'm thinking about this, even though it's one test done only once in your lifetime, you don't interpret and read and share everything at that time, right? You do it at appropriate times in the life stage. And so there could definitely be a conversation held with every primary care doctor and patient at 18 that says, when you're ready, we can have this conversation and unmask if there is a hereditary cancer risk, and then address that with proper screening implementation guidelines.
So I was gonna ask, one of the, so bringing it back, I don't have an answer to your question about the one.
It's okay.
One thing I do wonder about some of the patents and people that own some, like, and how they would feel about that kind of thing. So, the purpose of this initiative is to integrate narrative medicine and to use these tools to help residents and family physicians have conversations with their patients about this. And I wonder, how do you do it? Like, what do you rely on? How do you teach residents to do this? And I guess
Yes.
the second or sort of follow-up question is, do you find yourself, because and I think that's sort of one of the implications of this initiative, do you find that since you're better trained in this or more well-trained in this, that you feel more comfortable asking patients about their family history? So sorry, it's like a three-part question. But.
No, that's okay. I'll try to remember all of it. But the comfort thing, right? So when we think about why are there currently still barriers to integrating this into family medicine, I think you can break it down into a few buckets, right? One is knowledge. We can fix knowledge, right? We can train ourselves and our residents and our students and our practicing colleagues. The knowledge gap we can fill. What's the best way to do that may vary and may depend on the learner, but we can definitely fill that. The next is the confidence, right? The confidence is not something that is necessarily teachable. And I think, to me, that's where the clinical decision support comes in. If we can rely on our electronic health record to be catching the red flags, to remind us that somebody's due for something, that here's the outline checklist of what is the minimum standard of care for this particular patient with this particular finding, that we leave every night completing our visits knowing I didn't miss something, right? That's, I think, what would give us the confidence to proceed. And of course, confidence, there's all sort of layers around this. There's just having the conversation confidence. There's actually doing the testing confidence, interpreting confidence, management confidence. But the more that I think we have standardized algorithms in this space, the more we're going to have comfort to open up these conversations, because we'll be supported by the algorithm and by the clinical decision support in our EHR. And I do think that's absolutely critical. But there's no doubt that just exposure time builds confidence, right? So the more we're having the conversation, the more confident we're going to be, the more we know where our resources are to go when someone brings something up, the more confident we're going to be in engaging in that conversation and knowing we might end up with a question mark, right? And again, I think it's really important that we train, and when I do train, getting to the training question, I train my residents and the med students that it is okay to be a physician and to say, I don't know. Because we can't know everything, especially in family medicine, right? Where our scope is endless. We cannot know everything, but what we do know is where to go find the information. And I think it's actually okay to tell patients, I don't know, but I'm going to go find this out and I'm going to get back to you. And that's an opportunity each and every time to learn and build our knowledge and, again, build our confidence. And I think patients respect that honesty from us.
Thank you. I'm not a clinician, so I do respect it when my physician says, I don't know, I'll let you know later. It doesn't bother me at all.
Yeah, surprisingly, right? Yeah.
Yeah. So when do y'all teach your medical students? Sorry, I don't want to take up all the air here tonight, but I'm at UMass Chan, and we started teaching first-year medical students in their first month about informed consent for genetic testing. I'm an ethicist by training, and some of our feedback was that it's too advanced there. So we're trying to find a time where to fit that into the med school curriculum. So just curious when y'all do it.
Yeah, so I don't know when it starts being integrated around the topic around informed consent for genetic testing in the medical curriculum. What I would like to do is normalize the conversation around informed consent in general for any testing in medicine. And then what are the subtle things that have to be, thought about with unique types of testing. But the truth is, every time we order a CBC, we don't actually tell patients we might diagnose cancer, right? We just are looking for anemia or something like that. And so we have ways to improve overall around our informed consent. And if we can standardize informed consent, teach it really well, then it's not hard to then extend it to genetic testing or extend it to an MRI or extend it to a procedure, right, or surgery. So, I think that informed consent, though, is a crucial element that we need to standardize and be comfortable with. And the truth is, I think most of us, especially the faculty who are probably on the call, are really comfortable with informed consent, right? Because we do informed consent quite a lot for procedures. And so it's just recognizing that we actually have this skill set and building upon the skill set that we already have, and knowing that it's not that much different to extend it to genetic testing.
I don't know if anybody else has any other questions, but I just want to say, Mylinda, thank you so much. I feel like this was so valuable, and really just a great conversation.
Well, it's my pleasure. I hope it was helpful and useful, and I'm so excited that you were all working on this project. So thanks for having me.
Could you
Did
put
put
your
my
email in the chat?
I was going to say, I was just about to say, I put it on the slide deck, but I'm going to put it in the chat. Let me just make sure I'm chatting everyone. Otherwise, only Rebecca gets my email and she already has it. Yeah, please feel free to reach out if you have questions, want to discuss something more in the side, or just interested in the topic. Obviously, this is my passion, and sharing it with those in the family medicine space is really important.
I just want to chime in, Rebecca. Did you by chance distribute the email I sent this morning?
I have not sent that out, but I will send it out to the Google group for everybody to read.
If you folks aren't aware, if you read Gemma, Piece of My Mind, the one that was just released, is a tremendous story by a family physician. It's called A Letter to the Aunt I Never Met, about she had a grandmother who died very young of breast cancer, and she went and got testing, came back, BRCA1 positive, ended up having prophylactic mastectomy and oophorectomy, hysterectomy before she could have children, and talks about the impact it had. And it's all written in a narrative form. It's it's the epitome of narrative medicine that addresses this very topic so beautifully. So I highly recommend it. It's just a page and a half, but it really nails the points down. Lovely.
Yes, thank you for finding that for us, Adam. Appreciate it. But we are almost at time, so I will just say thank you to everybody. Thank you, Susanna, for moderating, and Mylinda for this wonderful presentation, and agreeing to come and speak to our group. I know that everybody who did not make the session tonight is going to be eager to see the recording of it, so I appreciate it. So thank you. I want to remind everybody that we do have resources available in our shared Google Drive. So if you want to get those fact sheets from the Bring Your Brave campaign, you can go in there and have a look at them. I will put the recording up, as well as all the resources that we've seen tonight. And I hope to see you all again soon.
Thanks, everyone. Have a good night.
Thanks, Bill. Good night.
Thanks, everybody.